Hello, my name is Juana Williams, and I'm going to talk to you about the importance of oral health in VAP prevention. Ventilator-associated pneumonia is a nosocomial infection that is very common within the ICU setting. It is also one of the most common hospital-acquired infections, according to the CDC. Mechanically ventilated patients have an incidence rate of anywhere from 9 to 27% of VAP. The mortality rate attributed to those patients who do get diagnosed with VAP is anywhere from 24 to 76%. It increases the hospital length of stay, and the estimated cost of VAP is anywhere from $30,000 to $40,000 per patient per occurrence. Ventilator-associated pneumonia is defined as hospital-acquired pneumonia occurring within 48 hours of initiation of a mechanical ventilation, especially with an ET2 tube. Now, this initiative will take place at 4 Northern Indiana hospitals. The population of interest are going to be all adult patients that are mechanically ventilated within the ICU or IMCU. The intervention of interest is going to be oral health, particularly oral health assessment, mechanical brushing on all patients at least twice a day or every 12 hours, and chlorhexidine use with your oral care. The comparison of interest will be usual care, and the outcome of interest that I will be measuring is the incidence of VAP. Now, a literature review and synthesis was done, and there was general consensus within the definitions of oral biofilm formation, the pathogens that colonize those oral biofilm, oral care, mechanical brushing, the use of chlorhexidine, especially among intubated patients, and comprehensive oral care guidelines. Now, oral biofilms and biofilms in general affect the course and pathogenesis of a number of systemic diseases, and those include diabetes, heart disease, preterm birth, and VAP, or lung disease. Now, biofilm occurs at multiple sites. The primary sites include the mouth, the bladder, when we put a catheter in place in a patient, and as well as any ports or devices that we insert into our patients for access. Secondary sites of biofilm infection include artificial hips, organs, and septicemia. And it's not just limited to just artificial hips, it's any implant. Now, what is an oral biofilm? Well, it's bacterial population that adhere to each other as well as the surfaces of the mouth. That includes teeth, the ET tube, the tongue, any oral mucosal surface within the mouth. The biofilm involves the surfaces within the mouth that includes living tissue, the mechanical devices, and it's very much like it occurs in nature. For example, your drainage pipes at home, or even your fish tank. If you touch the side of the fish tank, you'll feel the slimy biofilm on that tank. These biofilms are very complex, very differentiated as far as the multi-species communities that exist within them. Now, the spread of infection occurs from the transitory bacteria that initially starts out in the oral cavity and then makes its way, when we intubate, into the alveoli in the lower airways of the patient. It also leads to injury in the circulatory system due to microbial toxins, inflammation. Inflammatory mediators are released that attack both the parenchyma of the lungs as well as organs once it becomes disseminated and the patient becomes septic. The dental plaques are reservoirs for both gram-negative and gram-positive bacteria that eventually become resistant to antibiotics. Now, the nature of biofilm is to survive. These microorganisms have evolved, and there's over 500 bacterial colonies in a clean mouth, never mind a really dirty one. They adhere to each other, they coagulate, they become sticky, and they start mutating and exchanging genetic information. Inflammatory responses from the body are blocked by a layer of the sticky, slimy stuff around them, and then acidity occurs within the biofilm, as well as antimicrobial resistance to antibiotics. And as we know, most of our COPD, emphysema patients that are at risk of being intubated, a lot of them will be on 2 antibiotics. By the time they become intubated, many of them are on 3, and your resistance just skyrockets. Here is a picture of oral biofilm. The sticky area is the one around in the green part. That area covers and protects the bacteria within the middle that are purple, and that's where the actual action is occurring with as far as resistance and mutation. The sticky area, it prevents the host immune system from attacking it, as well as your chlorhexidine if you're not brushing. So chlorhexidine alone will not destroy this biofilm. Now here's just a picture of how the different bacteria will start mutating and exchanging genetic material and becoming resistant. Now this is how the progression of your biofilm formation occurs. It starts with tooth surface as well as your bacteria, and then they multiply, they start exchanging genetic material, and then they start to grow. And then it goes from lateral growth to vertical growth, and then they even establish their own water channels so that they can transfer nutrients and fluids in order to accomplish their Now here you have growth of 0 to 4 hours. Here is a patient with dental plaque and oral biofilm all within this mouth. And at 0 hours, if you see in picture A, you have a clean surface with just the tooth, and in picture B, at 4 hours you could already see the bacteria starting to grow and puddle up. The little bubbles are just your little colonies starting to aggregate. Here's a different picture. Few bacteria, separate colonies, bigger colonies, and then eventually your microorganisms that are resistant start breaking off and heading to other parts of the body. Here's another picture of the same thing. You have your bacteria growing, forming colonies, and upon intubation of this patient, you have the bacteria being introduced to the alveoli where oxygen exchange will be interfered due to inflammation. Now, the human mouth is a unique microhabitat for these multi-species bacteria that come together to form this oral biofilm. There's a selection process for very pathogenic bacteria. There is a genetic material exchange, and then coupled with the pressure from their environment or even the acidity of the mouth or antibiotics or chlorhexidine without brushing, the selection occurs and more pathogenic bacteria tend to grow. So what is important is that we continue to do oral care with toothbrushes. We need mechanical brushing of the teeth every 12 hours. So 7 a.m., 7 p.m., always with a toothbrush. Just cleaning the mouth with a sponge, like I said, will only touch that biofilm, and it will not disturb or contribute to its destruction. So please brush. At some facilities, oral chlorhexidine is within the toolkit for oral care. If your facility does not carry it or does not have it integrated into the toolkits, please order it from the pharmacy and RBVO it as part of this as part of your VAP protocol. Go ahead and use it every 4 hours, and especially after doing oral care and mechanical brushing. The next thing is to document. As part of this project, I have shown you the sheet that I put together so documentation can occur. Please mark the facility where you're at, the date of intubation, as well as your scores. You can see that from most of us who practiced before Epic, back when we had paper charting, we did in fact assess lips, gingiva, tongue, teeth, and saliva. Your patients with COPD and emphysema will score higher, mainly because they're breathing with their mouths open, or they're on BiPAP, trying to bridge them before intubation, trying to avoid intubation. So they're going to score higher. Your anaphylactic patient that went down, is young, brushes their teeth 2 or 3 times a day, they're going to have a healthier mouth. So please score it down the way. And where you guys are keeping, every facility is different. That's where those sheets are being kept. But there is a blue binder at every facility. If you have a patient that's intubated, this should be filled out. I also want you to take a look at the mucosa of the patient and the plaque. Just because patients do not have teeth does not mean that they do not have plaque. I want you to take a look. If there's yeast, if there's white patchy on their tongue and it's red, please tell your primary care provider that something's going on so that they can assess and intervene as appropriate. It might be an infection or it might be a cancer, but if you see something that's unusual, please let them know. We will continue to monitor any inconsistencies in VAP. My goal is to make sure that we can each decrease the incidence of VAP in all patients, only because the risk of death is so high, and we all want our patients to not get worse. We don't want antibiotic resistance within our ICU communities. We also do not want an excessive cost of healthcare. Like I said, every case costs anywhere from $30,000 to $40,000 to treat, and increasingly Medicare and Medicaid will not reimburse for an incidence of VAP, treating an incidence of VAP. So in an effort to save money and save lives and decrease resistance within our ICUs, it is important to stay in tune with the literature and with oral care. Thank you for listening.